Hi, everyone. We're glad you're here. Welcome to Samaritans Purse International Health Forum. We're so glad that you guys would join us today. We hope you'll all participate with us. You can chat with us in the little chat box beside your video. So we'll open up to questions later on in the presentation. My name is Kelly Seitz. I'm a disaster response nurse, a DART nurse with Samaritans Purse for about 7.5 years. Before we start and I introduce our guest, let's start with some prayer. Lord God, thank you for this beautiful day. God, thank you for giving us skills and minds to serve you with. God, give us a pure heart. Give us obedience to go where you call us to go and do what you call us to do. We glorify your name today, Father, and we thank you for all you've done for us. In Christ's name, amen. So welcome, everyone. I would like to introduce our guest today, Dr. Colleen Kraft. She's an associate's professor of pathology and laboratory medicine in the Division of Infectious Diseases at Emory University. She is also trained in medical microbiology. She's the medical director of microbiology section of Emory Medical Laboratories. Dr. Kraft was one of the infectious disease physicians at Emory Hospital, and she received and cared for the patients who had contracted Ebola and Lassa fever in West Africa, including Dr. Brantley and Nancy Wright-Bull. She was also a liaison to the laboratory and outside research institutions. Dr. Kraft has an MD from Indiana University and an MSc from Emory University in clinical research. So welcome, Dr. Kraft. We're so glad you're here.
Thank you so much, Kelly. And it's really my privilege to give this talk to you. This talk that I'll be giving today, which is on emerging infectious diseases and the role of hospital and public health laboratories, is also a talk that I gave for the American Society for Microbiology. I really wanted to give you all this talk partly because I think that many of you are on the front line of making these diagnoses and also raising alert to possible emerging infections. So again, this is my disclaimer that these opinions are my sole responsibility. Next slide. And I don't have any financial conflicts of interest to disclose. So we're going to talk about three main things today. Most of you probably already know about bullet point 1. You already know and understand how emerging infectious diseases occur and are transmitted, but I'm hoping to give you a little bit more information. Essentially, many things cause these things to occur and transmit. So we'll go through sort of a laundry list of what that may be. We want to describe the role that the hospital has in the detection of these emerging threats. So in the United States, there's the American Public Health Laboratories that basically interface with hospital laboratories to be able to feed that information into the CDC or other national laboratories. But obviously there's a global role in how that can occur. And then we want to learn from some recent specific examples, including Ebola, of the interaction between hospital and public health laboratories in response to these emerging infections. So really, there's probably lots of definitions, and we could know this intuitively, but emerging infections are infections that have newly appeared in a population or maybe have existed previously but are rapidly increasing in incidence or geographic range. I think an easy one to think about is just Ebola in West Africa. Next slide, please. So there's lots of contributing factors to emerging infections. Obviously, for influenza, it's really easy. We know that the virus, because it finds hosts in pigs and in birds, that it can mix some of those viruses together and they share genetic information, which then creates new pandemic and epidemic influenza. We saw that specifically in 2009 H1N1 pandemic. That was a triple reassortment of a number of different influenza strains. And the reason that it was such a big deal is because many of us did not have any immunity anymore against that because we had not seen that particular strain before. Obviously, changing human susceptibility. We think about HIV and AIDS, but as we become more advanced in keeping people on immunosuppressive agents and giving them organ transplants, we have basically increased human susceptibility with increased immunocompromised individuals. Climate and weather is something that I've been thinking about a lot in Atlanta. We've had an excessively rainy spring and summer. And so West Nile, while I was rounding in the hospital just a couple weeks ago, we had 2 patients that had West Nile encephalitis, which is more than we often can see in a year. So just how plentiful the zoonotic vectors are can really influence how many people actually get that disease. So changing in human demographics, I think we all know that rapid travel enables diseases to go around the globe and also find themselves in places where there are susceptible people. Economic development even can be a possible contributing factor if we use different antibiotics to decrease infections. Could we lead to antibiotic resistance? If there is a breakdown of public health measures, poverty and social inequality, which many of you on this call will be very familiar with, that sometimes things are transmitted and remain persistent in different environments because of our ability and for costs and other reasons to eliminate hosts or vectors for these diseases. War and famine, Kelly just said that she'd been in Iraq. Obviously there are health needs that are cannot be addressed, or new health needs that come up. I know that in West Africa as well, and again, this group knows way more about this than I do, but in West Africa, people couldn't get other basic health needs addressed at times because the infrastructure was focused towards controlling Ebola virus disease. Bioterrorism can also introduce emerging infections, and a lot of money and interest is spent by our government in the United States to try to prevent these type of things, but it definitely contributes to the outbreak of these infections. Next slide. And so this graph kind of appears funny to me now. I was back in 2004. I gave this talk before 2014 when we had patients with Ebola virus disease that we were brought back to the United States. But you can see loss of fever is on here in West Africa, but we would also put Ebola virus on this if this was a map that was more modern, because although it was not a emerging infectious disease in that it's completely unknown, it would be considered a re-emerging infectious disease because it is essentially something that we know and how to diagnose it, but we didn't know that it could be sort of in that area of the world. And you'll see on here the one that's the only intentional and deliberate emergent infection is that anthrax bioterrorism that was in 2001. Next slide. We know that infectious diseases do take a sliver of mortality as compared to other causes of death, but they are often dramatic and really can lead to a lot of transmission. And this burden also falls heavily on persons in developing countries. So in developed countries, infectious diseases disproportionately affects indigenous and disadvantaged minorities. And so it's something that we really want to focus on and try to prevent when we can. On here, we can talk a lot about what's being transmitted. And so we know that viruses certainly get a lot of press, but it's really actually bacteria, rickettsia, that make up the largest proportion. And this includes things such as things that aren't as fiction-worthy, as I like to call them, such as drug-resistant organisms in the hospital. And so we think a lot and we plan a lot for viruses, but we also know that a lot of them are just preventable or treatable bacterial diseases. And the peak that happened in the 1980s, if you can see that by decade, this was really the onset of HIV, and it brought with it a number of re-emerging and emerging infections, such as pneumocystis pneumonia and other various infections. So we know that infectious diseases will continue to emerge and reemerge, which leads to unpredictable epidemics and difficult challenges to public health and to microbiology and the allied sciences. And surveillance and response really depends on rapid clinical diagnosis and detection and containment in populations and in the environment. And I think that that's what this group has really impressed, Samaritans Purse has really impressed me about surveillance and response that occurs. That you have you've been leaders at the forefront of doing this. Disease detection and diagnosis. So these are just basic terms. We think about detection. Besides being an infectious disease physician, I live in the laboratory world of diagnostics as well. And we think about detecting or discovering maybe a novel emerging or re-emerging disease and identifying its cause. And then just with diagnosis also, just being the cornerstone not only of effective disease control and prevention efforts, but utilizing that surveillance to then bring us, we may not be able to detect it, but we want to diagnose that there's something happening and try to figure out how we can prevent it and look for it among other individuals. So disease surveillance and detection really relies heavily on the astute individual, the clinician, veterinarian, all of these individuals who notice something unusual, atypical, or suspicious, and then bring it in such a way to the attention of a representative of human public health, veterinary medicine, or agriculture. And that's what I really feel like a lot of missionary organizations are really on the forefront of, essentially trying to figure out if this is something that's typical or atypical, and how is it diagnosed, even in resource-limited settings. Just understanding that there may be something that's coming about would be very important to preventing larger outbreaks of these types of diseases. And so there's, these are all surveillance terms and epidemiology terms, but passive surveillance is probably what we all do all of the time. So while I was rounding in the hospital, and I had 2 patients that both had West Nile encephalitis in the same week, I was taking care of both of them, and so it was very easy for me to realize that this was unusual. And so I just simply sent an email to our state laboratory, but also just colleagues, just to make them aware that I was seeing this a lot and diagnosing it more than I had usually. And that's as far as it went, kind of informing my colleagues that something maybe unusual was happening, or just kind of in a passive way. Active surveillance is really what the health department tries to do when they get feeds from different clinical laboratories and different healthcare systems. And so they're trying to piece together that information and then kind of always be looking for evidences of increased numbers of certain diseases. And so that is obviously much more costly and labor intensive because it requires sort of 24 hours or full-time dedication to finding out if there's things or looking through this information, rather than just sort of noticing, oh, there's an increase in or a surge in something. And again, this group that's on the phone knows much more than I do about this, but just the context that you're working in. So, and probably I shouldn't be using the terms developed and developing anymore, but resource-rich settings may have the ability to detect and diagnose and have some sort of active or passive surveillance, but many resource-limited countries, where most of the global population resides, again, this group is very well knowledgeable about that, often lacks the resources or infrastructure to support the activities. It doesn't mean they can't be done, just means it may be harder to tell if something has increased in virulence or frequency. So diagnostics are really important for emerging infectious diseases, and this is something that somebody like me who's interested in diagnostics is always thinking about. So we want them to be early, rapid, and accurate. Of course, we would love everything to be that way, right? Even our regular clinical care. But in this case, we are looking for ways to prevent transmission, to prevent disease, and to prevent infection by making this diagnosis early and accurately. So now I'm going to describe the role that the hospital has in the detection of these emerging threats. So laboratory testing decisions are also, I think, really context dependent. In the United States, public health laboratories are governmental reference laboratories that protect the public against diseases and other health hazards, and they do way more than just infectious diseases. Obviously, I'm focusing on that because that's my area of specialty, but they do things such as newborn screening, food safety, emergency response, and environmental health. And preparedness, I think, is something that I will tell you, when I gave this talk a few years ago, I did not really understand at all what that really meant. And now I was also telling Kelly prior to this talk that there's not a day that doesn't go by that I don't think about Ebola virus disease still, because we are working with the Assistant Secretary for Preparedness and the Centers for Disease Control to create domestic preparedness in the United States. As sort of an all hazards approach. And so obviously all of these things are needed, and I think more than ever, those of us who have been in this setting of preparedness, if you've been in it for decades or just recently in it because of recent epidemics, that this is a very complicated thing, and you have to use more than just your own resources. You end up being part of a big infrastructure that is going to put resources and put information towards this preparedness. So clinical interactions are key. Healthcare infrastructure is also key, must have the support at the healthcare level. Trying to figure out how you want to report things, have triggers, flags, and then just support even outside of your institution. So lots of levels of engagement, lots of levels of support, lots of communication that is needed. So for instance, when we started receiving patients in the United States with Ebola virus disease, some of us had dedicated laboratory systems and physical laboratories dedicated to high containment units or high biocontainment units. And so we basically came up with test menus. Well, if you asked University of Nebraska or Emory or Bellevue or different places, they all had different testing, and it all had to do with the context. So Nebraska has this really cool thing where their public health laboratory happens to be on their campus. And so they can do, if you look at this little graph, the laboratory location of where these were being done could be done in a core lab in the biocontainment unit, or it could be done in a core lab in the hospital, or it could be done in the health department. What a great campus on which to perform all sorts of testing and really be able to give every layer of testing to a patient that might be admitted there. At Emory, we were really confined to what we could do in our point of care testing, but became very creative in what we brought in, and were able to also, what we felt like was offer a very wide variety of a test menu, and what we actually ended up needing might not have been every test possible, but we felt like it was the ones to keep people safe and keep them until their viremia cleared. So what are our choices for making assays and diagnostics? Well, you can develop your own diagnostic. This takes a long time, and if you want it to be used in other settings, you have to do an FDA application. But you can purchase your own assays. You can send out to referral laboratories if those exist wherever you are, or a public health laboratory if they have that assay. You can send it to the CDC, or I'm sure there's other possibilities. I'm going to talk now about some recent specific examples of the interaction between hospital and public health laboratories in response to different emerging infections. The first example I'm going to talk about is enterovirus D68. We had at Emory an established relationship with the CDC's Picornaviridae branch, who did testing for polioviruses and other picornaviruses. So we would often send samples via the state public health in Georgia to the CDC for testing when we had a patient that may have an interesting, have a myocarditis that we wanted to look into to see if it was caused by an enterovirus. It didn't really change our patient management, but we also found by working with them that we had a cluster of this enterovirus D68. And I like to joke with people that we had published a paper with them before it was cool to have diagnosed enterovirus D68. But we were able then, with that group, since we had that relationship, that we were able to find these different and novel enteroviruses in our own healthcare system, and be informed by that information. And again, it did not change our actual patient management, but we were able to describe what could have been, and was actually a few years later, and what was thought to be an invasive human enterovirus, and caused some paralysis in children, as well as some respiratory distress. For Middle Eastern respiratory syndrome, which is a coronavirus, we also worked with our state public health laboratory to have a 4 to 8 hour turnaround after testing is cleared by the state epidemiologist. And this was quite a feat for us here in Georgia, just because we usually are used to about 24-hour testing as being the fastest we can do, but we realized that we really needed to isolate these individuals if it was possible that they were high risk for acquiring the coronavirus MERS. And we did have one example of a patient who needed to be ruled out for both Ebola virus and MERS. And so having that rapid turnaround was really helpful, because we could, we needed to hold them for testing for Ebola virus, which we could do within an hour or 2 hours on our film array. And then we could also rule them out for MERS. So that was somebody that needed 2 sort of high risk testing. And we were able to do that within a day, which meant that resources weren't consumed in personal protective equipment and caring for this patient. And for Ebola virus, prior to July 2014, we had never considered how the testing would be performed in our healthcare system. And so we had an unusual situation at Emory where we admitted known patients, who you all know on this phone line, into our healthcare system. And we had funded since, we'd been funded since 2001 to support CDC workers with laboratory or field exposures. The reason that it was 2001 was that intentional introduction of anthrax into New York City and elsewhere essentially caused people to want to prepare and have units where individuals with special pathogens or serious communicable diseases could be admitted in a safe way for the healthcare workers. So I'm going to just focus on our diagnostic aspect. Obviously, there's a lot more about the clinical care of these individuals, and I'd be happy to come back for another webinar if there's interest to talk about the care in resource-rich settings for Ebola virus, which is very different than what our colleagues, including Kelly, have done in Liberia. So we had an isolation laboratory in place when we got the call on July 31st that we would be receiving Kent Brantley. We had a small 4-foot hood in the corner of the patient anteroom. We had a blood gas analyzer. We could do a comprehensive metabolic profile, a CBC, a urinalysis, and an INR. So the immediate decision that we faced on that day was, where does this testing going to occur? So if we did it down in the unit, then there would be less fear among the hospital and lab staff and less impact on staffing and patient care in the hospital. We had many individuals who said that they were not coming to work if the patient's testing was going to be performed in the main laboratory. And if it was done down in that the laboratory near the unit and near the biocontainment unit, we would get very immediate results because we'd have dedicated staff just performing those tests for that patient. So it's really staffed. The disadvantages, though, of having a dedicated laboratory in the biocontainment unit was that we had a limited test panel, as I've described a little bit. And if we had a machine that went down and there was no backup, and we knew since 2001 the cost of maintaining equipment rarely used had been very difficult. So we were ready. Thankfully, we had some notice. So we had 72 hours notice. So we purchase reagents through overnight delivery. We had to revalidate all those analyzers, and we had to order a replacement hematology analyzer and validate it. So the first patient with Ebola virus disease arrived to Emory. There was a lot of new challenges that we then faced. There was community scrutiny and fear, more media coverage than anybody had ever thought could happen. We were also learning how to communicate as a team within the healthcare system, within the community, within just our team that was taking care of patients. And we had to try to do the very first test in this patient. So the laboratory had a representative, often many representatives, who attended our huddle that we had every morning at 7:15 while a patient was admitted in our biocontainment unit, and the agenda items that were needed for laboratory testing that day. So we tried to foster team building was absolutely crucial. Everyone's concerns mattered, and we really tried to be provider-centered as well as patient-centered. And then we had patient 2 coming, and can we move the laboratory to make more room for the second patient and preserve that cleanliness of the anteroom? So you can kind of see here that red line that goes from the anteroom, where it had been in the hood, to we overtook an office just down the hall from the biocontainment unit and created the laboratory to be a dedicated laboratory there. And this was still all changed before even Kent had arrived. So we worked with facilities. They built the new laboratory overnight. They set up the hood. They put up those backup analyzers in the new space, and then they reevaluated all those safety steps, because now we were doing laboratory testing in a different room. And they had to do donning and doffing much differently than we had done in the anteroom. And we had to retrain the staff. So all this was happening in a matter of hours, essentially. So here is the new isolation laboratory, as we called it then. Now we have an even newer one, but I don't have pictures of that. I can get them for another time. And so this was nice because it really separated the laboratorians from the clinicians and made a lot less thoroughfare in that anteroom picture that I'd shown you prior. And it also allowed them to have a lower risk because they were working with known positive samples, and they were working in a hood and in very typical laboratory conditions. So they weren't leaning over in a hood in an area where people are going in and out, and they weren't using devices that maybe had centrifugation in them, essentially keeping things that might be contaminating the environment in the laboratory out of the anteroom. So this ended up being a very critical decision, I think, that helped keep people safe. And then our third patient arrived. So he brought with him additional challenges. So we initially just had an on-call technologist. They would come to that 7:15 huddle. We would give them a manual requisition because we never wanted to trigger a phlebotomist to try to come down and draw blood. So we just manually ordered our laboratory tests. And they had essentially covered for that morning laboratory run. With our first patient, we ended up splitting it into 12-hour shifts so people could go home, and even if we needed an extra laboratory, clinical laboratory test run that day, they could be assured that they wouldn't be here 24 hours a day. But we ended up then staffing our third patient, who was critically ill, with 2 medical technologists. That was so that one person could watch the other, and they had 6-hour shifts. So if you do the simple math, that's potentially 8 hours of staffing just for a medical technologist a day. And these people were doing their other jobs as well. Most of them were in our point of care laboratory group. And so we had our isolation laboratory staffing numbers grew immensely. And during the peak of our very ill patient, we had almost 20 just medical technologist volunteers trained. And we maintained a readiness of about 9 to 10 over the next 8 months. So there are many roles of the laboratorian. So there's the testing technologist, who you can see sort of inside that door. All of the operations inside the laboratory they were responsible for. not only testing and ordering, but they did reporting and we did cleaning. So neither in the patient room or in the laboratory was there ever an environmental services or any house cleaning type individual. All of that cleaning was done by the clinicians and the laboratorians and the technologists. We also had a buddy in safety. We didn't have this initially. Initially, the person that was a resource nurse was kind of doing both, but we decided that this person in the laboratory needed just as much supervision as somebody in a patient room. And we wanted to ensure proper donning and doffing, to liaison to those clinicians and nurses, and to transport samples and supplies. They also assisted with trash removal from the laboratory. And we also had laboratory directors and laboratory administration involved, and those are the individuals that brought in tests, gave us different direction on things we should be doing. When we would have analytical problems, such as interfering substances in our patients, they would also provide some help if we needed to do something different with the preparation of the samples. So we ended up, because our third patient was critically ill, requiring dialysis and ventilatory support, we ended up having to add things like phosphorus because we were giving them a calcium infusion, buffered infusion. We had added an amylase because we were concerned about some pancreatic involvement. Magnesium was very critical given that he had renal failure, and creatine kinase as well, just for rhabdomyolysis. We also added another biofire that we used for testing all of the bodily fluids that came out of this individual to just try to assess the risk of the patient's fluids to the healthcare providers. We added panels to expand testing. We ended up, besides just doing the bioterrorism panel, so this was from the biofire film array just to diagnose Ebola. We also used the gastro pathogens panel and respiratory panel, and eventually the blood culture panel, because these were all much safer than doing these things by other means, such as culture, at least for our institution. We also had some bedside testing. We decided to let laboratory technologists do the laboratory testing because they did the best at troubleshooting the different assays, which was really required in many cases in our patients. So I had mentioned this a little bit before, but we ended up having interfering substances with some of our patients. And it's pretty unusual if you think about just taking care of 4 patients with Ebola virus disease, that 2 of them actually had substances that interfered with our machinery that we were using for testing. So it's a pretty high percentage. So one of our patients had a cold agglutinin, and so every time we would try to test the CBC, it would agglutinate and we wouldn't be able to get an accurate reading. So we ended up using a sample infant heel warmer that we got from our neighboring children's hospital in order to keep that CBC warm so that we could actually get an accurate blood count reading. And as you know, if people are bleeding or having hemolysis, it's really important to have the right blood test level or hemoglobin. We also had a patient with lipemia, and so the patient had been on some TPN, but the lipemia started earlier, and we're assuming it's because of the profound sepsis that the individual had. And so what would happen is that the laboratory technologist was noticing this lipemia, and it was changing the values of the our piccolo, which did the metabolic panel. And so those readings became more and more inaccurate. So we ended up having to use the ABG machine with the electrolytes that you get off of a blood gas in order to give the correct information for the patient. And you can see this is our first method. You like the whiteboard there up on the right. This is how we would do our testing orders in the beginning. And then later we would actually put it into the computer. But this is what we came up with. Again, we were trying not to trigger the ordering of any blood draws through our typical power chart system. We didn't really have a way easily initially of doing that. So we just did a manual requisition since we were all down in the biocontainment unit together. And this would be filled out and handed to the laboratory technologist in the morning. We also evolved in the sample transport within our unit, and so we collected the samples and labeled them in the patient room, and then we put them in a specimen bag, closed it, wiped it with a germicidal wipe, put it in a secondary bag, cleaned that with a germicidal wipe, and then handed it to the laboratory technologist in the anteroom. What we ended up doing after that was that the nurse in the anteroom would take it, wipe it down yet again, put it in a hard box, and then give it to the laboratory technologists. And you can see here, this is the locking lid plastic specimen box. And then that was also cleaned with a germicidal wipe. And then that was handed from the anteroom to the lab safety person. Remember that buddy that I'd showed you earlier? And then there was a handoff from that safety person to the testing personnel. And the box was cleaned by the testing personnel again and returned back to the anteroom. So specimen storage also became a big deal, and I sort of, it's a lot different here than in other parts of the world, but known positive patients here fall under the strictest storage requirements that anything can, because they're considered, if you culture the virus from these, they're considered select agents. And so immediately you fall under the jurisdiction of the Division of Select Agents and Toxins, which wants to know at all times where all of your samples are. And so we had a locked refrigerator with inventory record sheets in our anteroom, and we had a disposition of all known positive samples that was monitored on those. Our laboratory waste in a safety cabinet was collected in a Sharps container, and then other waste in a biohazard bag was in a foot-operated waste bin. So we add water to these, we gooseneck them, we wipe them, and so then they are then autoclaved in that first and second bags. And then we actually mark whether it's positive or negative from the laboratory, and make sure that we've tracked the, if we know it's a positive specimen in there, we've tracked through all of the autoclaving and transport so that we can always tell Division of Select Agents where the storage is. Again, all of this makes me chuckle, as I had an opportunity to volunteer in Sierra Leone last May, where we did where I worked with an ophthalmologist to look at patients, Ebola survivors, and we would just send our samples down the road in a cool box in the back of a pickup truck, and nobody was caring about that at all. But it's a lot different in the United States. Select agents are a big deal and fall under some pretty impressive regulations. So clinical settings are indeed exempt from regulations, but you're still required to document and track all of those specimens like I've already described, and provide all this form work, or you will be fined and shut down. So it was a big learning curve we hadn't really thought that far ahead in all of our drills prior to receiving patients with Ebola virus disease, that all of these regulations were going to start applying to us. And also that the Division of Select Agents and Toxins also doesn't usually interact with clinical settings, so they're really good at all of the biosafety lab for research laboratories, but dealing with a hospital was sort of a new idea for them. So that became very interesting. The cost of readiness is something that we also think about every day. So I mean, just having 2 technologists and a laboratory director on call 24/7, 365, we're not even talking about nursing, physicians, clinical care. Operating expenses are very expensive, maintenance of all these methods, in-date reagents, semi-annual validations, proficiency testing, personal protective equipment. All of this becomes very expensive. And we also had a lot of workflow charts like this. You're not meant to read it, but we had, this is what one of them started out to be. So if you squint at the top, you can see there's a low risk, intermediate, and high risk. So this was the laboratory perspective on it, and I helped with it a little bit. But as we were going through, we just realized all we needed to know from the laboratory perspective is, do you want this patient tested? Are they high risk enough for Ebola virus disease, or do you not want them tested? So we started throwing out all this low risk, high risk, and just asked somebody has to make a decision and then notify the lab. Because what we would do for all our persons under investigation is we might, even though we might not activate the unit, we would still activate that laboratory, dedicated laboratory, to do the testing for Ebola, for these rule outs. And so it, we overhauled this workflow a lot. So not just in the care of the 4 patients with Ebola virus, and we also had 3 very high-risk exposures that we also cared for in our unit that didn't make the news, thankfully. But the way that we were doing it for all the other individuals that were testing negative eventually, but there were persons under investigation, is that a physician in the emergency department or Travel Well, that's our ID physician outpatient clinic, would call the serious communicable diseases unit doctor, that would be myself or my colleagues on call for a consult. We would discuss whether we thought a patient was high risk enough. And then we would also then call the lab director, who would then call the lab staff, and then we would figure out where the specimen was and then make sure the tech was going to meet the specimen. And so just simply testing somebody for Ebola virus disease that was at risk for it was a very big process. So in short, the more scenarios that your institution faces allows for increased preparedness for the future, and everybody always has to customize the response and play to the strengths of the system. Hospital and public health laboratories are the backbone for diagnosis and detection and should have a place at the table and can be very helpful. So this is sort of what I think we think about going towards is this whole idea that we could diagnose anything and anybody at any time. And I would tell you that we're still quite far away from that, even though we have all these really neat sequencing and just the support of these things and getting them in country and making sure they function in country, we're still sort of far off. But it's definitely what people are looking towards and excited about in terms of trying to figure out if we can have some sort of pathogen identity or pathogen discovery anywhere at any time. All right, so I've ended a little bit early probably for you guys, but I'd be more than happy to take some questions now.
Dr. Kraft, that was so fascinating. Thank you so much. While we're waiting for a question, I do have one myself for you. You were talking about customizing your response. So you know that training for an outbreak response and then actually providing it is 2 different things. What did you guys run into that surprised you as you actually were caring for the patients? You had to kind of MacGyver and adapt and come up with new ideas that you hadn't maybe trained for. Can you talk about that at all?
Yes, I would say on every level we had something that we came up against that we didn't anticipate. So what we would usually do is have sort of like a consensus, so everybody at the table, you know, bedside clinicians, EVS, healthcare administration. I would say we did a slow MacGyver. My sons are really interested in watching MacGyver these days, so it was a slow MacGyver. I feel like MacGyver is always doing these things very quickly. But we ended up really trying to slow down, force ourselves to slow down and think through things. Like the first chest X-ray we ever did on our critically ill patient essentially took us 2.5 hours. So, and those of us that are in the clinical setting, I mean, it takes 5 minutes. But we had to figure out, where do we get who, you know, first of all, is anybody gonna come down? We hadn't trained the radiology technologist to come into the unit. So they were gonna only be in the ante room. But then how do we keep the machine safe? We pushed the bed against the door so that we didn't put the machine into the room. And we had a developer, interestingly enough, a digital developer that somebody had, you know, surplused, that was down in our unit. So we could actually look at the chest X-ray before they took, we lost the technologist and they went back upstairs. So there was one day where we did a chest X-ray, which took a couple hours, and then maybe foolishly, we decided to spin the urine of our patient with renal failure. And so I did that in the lab. That also took about 3 hours because we ended up having to pull everything out of the ante room because we knew centrifuging something that could potentially have Ebola virus in it could spread. You know, we didn't know the implications of that. So I was looking in my PAPR in a hood through a microscope lens, and I'm not a nephrologist. So, you know, some of those things, you know, we were really concerned about contaminating our environment, but also we decided that there were some things that were not worth doing because of the risk benefit. So did it really matter if we knew the cause of the patient's renal failure at that point when he was going on dialysis anyways? Probably not. We were already giving him fluids, so rhabdo could have been the cause, but it didn't matter. If it was the virus, we were doing our best to support the patient. And so some of the things I thought, and we also decided to do PAPRs. That was something that we hadn't completely known ahead of time that we would universally use PAPRs. But we also felt like that was for comfort purposes of our staff, even though Ebola virus is not airborne, we liked the PAPRs a lot. So those were a couple, I have like a million scenarios, but I would say we in general tried to slow down and make decisions, and we forced ourselves to do that because we were afraid of innovating and then putting people at risk.
Yeah.
But it was a big challenge.
Those of us, it's always a challenge. Those of us who are in Africa are jealous of your PAPRs. We want to remind you, folks who are viewing this, you can post your questions for Dr. Kraft. You can type them out to us and we'll ask her your questions. So while we're waiting for that, I have another question for you. Did you and your staff have to do 21 days isolation after you took care of the patients?
That's a great question. So we did 21 days of monitoring, so twice daily temperatures. But what the state of Georgia finally allowed us to do was they gave the supervision of that monitoring to Emory Healthcare's occupational health. And so they just basically said, you're monitoring your own healthcare workers. So we did not have any restrictions on our movement, well, except restrictions that were placed by other other groups, like maybe cruise ships. I think I had some friends that were nervous that they weren't going to be able to go on vacation for the holidays. But we in general did not have to do any sort of isolation. But again, it's because the healthcare system took over that responsibility. There was also a lot of advocacy that was done in the state of Georgia because essentially we said, or our leadership said, we wouldn't be able to provide this care for people if we were going to undergo these types of restrictions. And so they decided that we were, actively doing our own risk assessments. We were actively monitoring we had, these health questionnaires we filled out twice a day along with our temperature. So they felt like that was an adequate isolation. But that's a great question because there's a lot going on at that time.
Yeah, definitely. No one's asking you questions. I think you were so thorough, but unfortunately for you, I have one more question for you since we have still 10 more minutes. But what about personally? How was the response with your family and your community? How did all those folks treat you, knowing that you were caring for the Ebola patients? Did you have any pushback from that?
So my family was very supportive, although my husband was essentially a single dad for about 6 months because we spent so much time at the hospital. So I didn't personally feel a lot, but I didn't see very many people for many months. Even people at work didn't recognize me anymore. I was just in my scrubs and ponytail. That's not my usual standard. There was a family in one of my children's schools that was worried about, their children being in the same school with my children. Yeah. Personally, for me, to be able to do this type of service, it was like a deep answer to prayer, I think. This was the whole purpose I went into infectious diseases, was Ebola virus, and reading that type of literature. I think a lot of people had read The Hot Zone and wanted to do work like this, but to actually get to be on the team that did this and to take care of such amazing people as well was really, it was very life-changing for me. And I had realized that there were a lot of fears that had held me back from doing different things domestically and internationally. And I think that facing this disease, although I did not face it in the same situation that you did, Kelly, and you have my utmost respect and admiration for being in West Africa, but it really changed my life and kind of changed my perspective of God and how he interacts with us and what he's capable of doing. So from a personal
Well,
standpoint.
thank you. Yeah, thank you so much. We're so thankful you took such good care of our friends. Dr. Kraft, thank you so much. That was so fascinating and so interesting. We want to remind everyone that CME credits is available for this session. The form and the instructions were sent to you in your email, so you can check that. We'll be sending a follow-up link to this recording so you can watch it again or send it to someone you know. If you're not on our email list, you can join the forum at health.samaritans.org and be the first to know about upcoming events. Our next webinar will be Wednesday, September 13th with Dr. Aaron Kelly. He'll be presenting disaster response preparedness on the mission field. So you don't want to miss that one. We hope to see you all there. Dr. Kraft, thank you so much for your time and thanks for all you do for infectious disease. We so appreciate it.
Thank you, Kelly. And thanks everybody at Samaritan's Purse.
Thanks everyone. Have a great day. We'll see you next time. Bye.